Hello. Hello. Hi everyone, and very good evening to all of you. I'm very sure that you might be very well and most importantly healthy. So, guys, I welcome you to this wonderful session I will be taking about, and this session would be about discussing the various, images of pathology. I've picked a few of them, not a many of them. I picked a few of them which I feel that has been a lot frequently asked question, and you should know about them. Okay, so what we'll do is we'll try to make it as interactive as possible. I'm actually live with you. So yes, very warm welcome, Mohan, Moinuddin, Anup, Himanshu, Siddharth, Chelsea, Ronak, Jan. Very good evening to all of you. So guys, please watch the entire lecture throughout this period of time because we will have a lot of doubts. I know that now you see an image, you have some of your thoughts, and I have tried to put a few of history in those images so that you can actually try to correlate them very well. Okay, so make sure that when you look at this image, you have some thought going on in your mind so that we can have a fruitful discussion with you all. Okay, let's start with the images, and the few images I want to tell you is yeah. So most selected image of pathology. First of all, tell me, is my audio and video very clear to you? So is my audio and video very clear to you? Is my audio and video clear? Yes. Hi, very welcome. Norma, Zeromwell, Mitlesh Mishra. Yes. Very good evening to you also. Guys, is my audio okay? Is my video okay? So if that is okay, let me start with the first image. And this is the first one. Chalo. This image is giving you an autopsy from a person who died of a cardiac arrest. Has been shown here. Now, what do you think is this image? Your thoughts first. So, what do you think is this? It's a cut section of the heart. Now, what to see in this cut section of the heart, as you see very clearly, you must be able to understand that this image is showing you. Look, this is a cut section of the heart. Now, this might be the ventricle, might be the right ventricle. This might be the left ventricle. And look at this area, this pale area, guys. Now you must focus on this area here, this one. So when you're looking at this area here, this area is showing you a white infarct. Okay, they're showing you a white infarct. This white infarct in this image is showing you an area of infarction. What is infarction? A localized area of necrosis. The same image is being shown here also. Now in this image, what you're seeing is, in this image, you will be able to appreciate, look at these pink colored fiber. These are the pink colored fibers. Now in this pink colored fibers, look at this completely homogeneous area. These are completely homogeneously pink areas, and you're not seeing any nucleus here. They are not nucleus. Usually the nucleus are like this. Usually the cardiac muscle have nucleus like this, but you're not able to see any nucleus because it's completely pink in color, and this is signifying what? A type of necrosis. A homogeneous pink color, it's showing you an area of necrosis. Secondly, try to appreciate these cells here. Now, can any of you tell me what are these cells, guys? Any idea what are these cells? Guesses? Any guesses, guys? What do you think are these cells? What are these cells, guys? Any guesses, guys? What are these cells? So what are these cells? These small cells I showed you, like this one or this one or this one. These are neutrophils. Okay, these cells you are seeing here, these are neutrophils. Okay, these all cells you are seeing is neutrophils. This pink area is showing you a coagulative necrosis. It's showing you a coagulative necrosis. Why it is coagulative necrosis? Because the cell outline is well preserved. Now this is the area of the heart showing you the same type of infarction. This is the area of the heart showing you same type of infarction. So definitely it is a type of coagulative necrosis. So what is coagulative necrosis? It's a type of necrosis where the cell outline is disrupted yet maintained. The outline is maintained. The color should be pink. Nucleus lost because it's catalysis, and yes, there should be neutrophils. Definitely there should be acute inflammation here. Okay, there should be acute inflammation here. Okay, these are what? These are coagulative necrosis. Now, why am I saying coagulative? Because you can appreciate the cell outline getting preserved here, right? If the cell outline is not preserved, it becomes a liquid necrosis. Most of the solid organ shows coagulative necrosis, except brain, which shows liquefactive necrosis. Yes, very, very good. Okay. Next question. See, brain autopsy performed to find out the cause of death in a 45-year-old male who died of sepsis. What is your diagnosis? What do you think it is? First of all, this is the brain, guys. I look at this area. It's showing you what? It's showing you infarct. Okay, it's showing you infarct. Okay. Now, this infarct in the brain is showing you here a necrosis. Now, when you compare this necrosis here, this necrosis was showing you a definite outline here. This is what the outline maintained here, right? But when you look at this necrosis and compare this to this one, what you're able to see is you are not able to see any cell outline. You see this area? You're not able to see any cell outline. There's no outline visible here. This area is signifying liquefactive necrosis. Yes, it is liquefactive necrosis. Now, if you are ever getting confused, sir, why are you calling this liquefactive? There are two reasons. Number one, the image here is of a brain infarct. And you all will know that brain infarct always show you liquefactive necrosis. This is one reason. That's one reason. Okay. The second reason I'm talking about that is, look at the morphology. Now, the morphology you can see here, these morphology you can see here, these are all characteristic of what? No cell outline maintained. The cell outline not maintained. Okay, it is not maintained. Cell outline is not maintained. Yes, very good. It is liquefactive necrosis. So Nidhi, Santosh and Rakshat, yes, you are very, very correct. These are types of liquefactive necrosis. Okay, so remember, now I have a few questions to you. Let me see how many of you can answer it. Let me see how I can answer it. Now I'm giving you some, question number 1, question 2, question 3, question 4. Okay, now you need to answer me the right answers here. My first question is tombstone appearance. Second question, colligative appearance. Third question, caseous necrosis is a type of. And fourth question is wet gangrene is a type of. Let me see how many of you can answer this in the live chat. Let me see how many. Please answer this as question 1 answer, question 2 answer, question 3 answer, question 4 answer in a single message. Let me see how many of you can answer it. Let me see that. So many students are watching this. Please like the video. Please like the video before you move forward. Okay, please like the video when you're moving forward. Well, come on. The answer. Well, the answer is, I'm giving you here, tombstone, coagulative. Colligative is liquefactive. Caseous is coagulative. And wet gangrene is liquefactive necrosis. So these are 4 questions which might be asked to you in the recent questions. So please understand, these are 4 important points you should be able to answer it. Yes? Okay. Next question. A patient presented with rapidly progressing hypertension and abdominal pain. Okay. So he has rapidly progressing hypertension as one history and he has abdominal pain here. The vessel of the kidney has been shown here. Now this is a vessel. Now why is the vessel? Look at this lumen. This is the L lumen here. This L is the lumen here, right? This L here is a lumen, right? This the L is lumen here. This one, right? Now what you're able to appreciate here is, look at this pink area. Look at this pink area. This pink area you're seeing here, this all pink area you're seeing here is what? It's a fibrinoid necrosis. Now why fibrinoid? Because it looks like fibrin. This whole area, this whole beautiful looking pink area, this is called as fibrinoid necrosis. What is this? It's a fibrinoid necrosis. Okay, it's a fibrinoid necrosis. Okay, why is fibrinoid necrosis? Because of a homogeneously pink area. It is homogeneously pink. Homogeneous pink areas. Okay, homogeneously pink areas. Now see, when you say a history of rapidly progressing hypertension and abdominal pain, what comes to your mind? It can't be atherosclerosis, because atherosclerosis will not show you fibrinoid necrosis. So can any of you guess, with these two history, what might be the diagnosis? With this image you're seeing here, and you're seeing these two history, what do you think is your diagnosis? What is your diagnosis here? Can any of you guess it? Can any of you guess it? Let me see how many can answer it. Yes, Nidhi, Santosh, Mansi, Rakshat, Santosh, Shivani, Dr. AB, Stranger Prasad. Wow, what a wonderful name. No, it is not atherosclerosis. It's not atherosclerosis, because atherosclerosis will show you a plaque formation. It is not plaque formation. What is it showing you? It is showing you fibrinoid necrosis here. So what do you think it is? Actually, it is polyarteritis nodosa. Okay, it is PAN. This is a history characteristic of PAN, polyarteritis nodosa. Very good, Santosh and Soumya. Very, very good. It is PAN. Very, very good. It's PAN. Guys, you have to like the video so that we can move forward. Okay, please like the video, and also share the video with your friends, because it's a, exam is nowhere near, so we can actually learn by discussing it a lot. So make sure you can also share the video here also with your friends. Yes, very good, very good. Now the people are answering it. Arjun, Sohaib, Sumer, Swati, Chelsea. Very, very good. Chalo, next question. So here's the question. A surgeon was operating on a case of acute pain abdomen. On exploration of the abdomen, mesentery shows the following. Look at this area here. Look at this area here. And look at this microscopy you see here. Look at this microscopy you see here. So what do you make out of it? What you're looking here is, these are the chalky white deposits, right? These are the chalky white deposits, correct? And what you're seeing here, this area, look at, these are the normal fat globules. Okay, these are normal fat vacuoles. But please understand this area. This area is showing you what? It's a complete liquefied necrosis. It's showing you a liquefied necrosis. Okay. So therefore, it's an example of fatty necrosis. It's example of fatty necrosis. Yes, very, very good. Let me just point out your names. So Nidhi, Santosh, Swati, Dr. AB, Mohana, Soumya, Amit, Raksha, Arjun, Vikas. So please, one video on scope of pathology after MD. Arey beta, huge scope. First get that MD. Okay. Shivani, Vicky, Dr. Great, Saurav, Stranger Prasad again, Sumer, Aditya, Rick, Mansi. Very good. Very good. Chalo, next question. Identify the pigment in the liver. So first of all, you should understand this is liver. Now, why is liver? Let me tell you. These are the hepatocytes, guys. Hepatocytes. And this area here having the blood cells. These are RBCs. These are the RBCs. They're sinusoid. These are sinusoids. Hepatocytes, sinusoid, hepatocyte, sinusoid. Okay. Hepatocyte, sinusoid. Okay. So what you're seeing here is, there are hepatocytes. Now what you should be able to see here is, these are the brown colored pigments. They're brown colored pigments. What are these brown colored pigments? These are lipo. Yes, lipofuscin. These are lipofuscin. Now, few questions that you will always encounter about this is, number one, the question that is usually asked, number one, this is actually called as brown atrophy. Okay, that is referred to as brown atrophy. Second, these are also referred to as wear and tear pigment. Very good, wear and tear pigment. Third, they're also called as sign of cellular aging. These all are the names of lipofuscin. Brown atrophy, wear and tear pigment, sign of cellular aging. Now tell me, in which organelle do you see the lipofuscin? Can you name in which organelle do you see deposition of lipofuscin? Do you see this in nucleus? Do you see in mitochondria? Or which organelle? Which organelle do you see this deposition? Can you tell me which organelle do you see this? Let me see if any of you can answer it. The right answer is yes. Come on. Right answer. Right answer. Right answer is, should I write it? Lysosome. Okay, it is not in the nucleus, it's in lysosome organelle. It's in lysosome organelle. Remember, it is perinuclear in location. It's perinuclear in location and is formed due to a free radical injury. It's formed due to free radical injury. Okay, it's free radical injury, but it is not mitochondria. No. It's not mitochondria. It is free radical injury. Okay, it's free radical injury. It's a free radical injury. Sign of free radical injury. Come on, next question. A 36-year-old has dyspepsia and abdominal distension. Okay, esophagoscopy done and a biopsy was taken from the lesion here. Which of the following is not true regarding the condition? Tell me. Come on. Finally, what is the answer? Well, in this question, remember this area is normal and this area is showing you a ulcer. Okay, you see this normal area has which epithelium? The squamous epithelium, and this area has not developed an ulcer. This area has developed an ulcer. Basically, it is what? This is showing you the squamous epithelium is here and this epithelium you are seeing here. What do you make out of it? See, this is the squamous epithelium. Now, when you look at this epithelium, it's definitely not squamous. These all are columnar epithelium. These are columnar epithelium, and look at these round cells here. These round small cells, guys. These round cells are the ones which are called as goblet cells. Okay, come on, fast. Goblet cells, they're called as goblet cells. It is called as goblet cell. Okay, now look at this image again. Now this image is showing you the same goblet cell shown here, and the stain used is Alcian blue stain. This Alcian blue stain is confirming that what is inside this is a acidic mucin, guys. Acidic mucin. What is inside this is a acidic mucin, and therefore diagnosis becomes, yes, very many of you have guessed correct. It is Barrett's esophagus. It's a Barrett's esophagus. What is a type of? It's a type of intestinal metaplasia. Okay, intestinal metaplasia, also called as columnar metaplasia. Now, can any of you tell me that what do you mean by a short segment Barrett's, and what do you mean by a long segment Barrett's? Let me see how many of you can answer it. Avinash Mukherjee asking me, where do we see alkaline mucin? But alkaline mucin, most of the mucin is alkaline, but in the Barrett esophagus, you see acidic mucin. Now, alkaline mucin is stained by past stain, okay? But the acidic mucin is especially stained by the Alcian blue stain, okay? Alcian blue stain. Very good, Avinash Mukherjee. Avinash, are you the Kolkata, my favorite student? So it is less than 3 centimeter and more than 3 centimeter. Okay, less than 3 and the more than 3 centimeter. Not 5 centimeters, 3 centimeter. Okay, it's 3 centimeter. Okay, 3 centimeter. Okay, chalo. You have to like the video, guys, and please share the video. Like the video and share the video so that most of the students can join and can benefit from the class. Remember, exam is nowhere near. We will only have good discussion to learn something good. Okay. Next question. A 48-year-old has polyurea and edema. Kidney biopsy was done as shown below. Okay. Now see, this is the pink area. The pink areas here. This one. The pink area here. What are these? These are well. Now let's go by one. We look at this pink areas. What comes to your mind? Let me tell you what should come to your mind. What should come to your mind is, number one, it can be multiple myeloma. Okay. Second, Why multiple myeloma? Because it shows AL amyloid. It shows AL amyloid. Secondly, you can think about diabetes. Thirdly, you can think about a fibrin deposition. Fibrin deposition. These all things should come to your mind. When you see a homogeneously looking pink deposit, these are what? The three things should come to your mind. Now, when you stain them like this, look at this one. Look at the apple green birefringence. Look at the apple green birefringence. So this becomes, definitely it can't be diabetes. It cannot be diabetes. Cross out this. It cannot be fibrinoid because this AL amyloid is being stained by Congo red stain. Stained by Congo red stain, and the Congo red stain is being seen on the polarized microscopy showing you apple green. Yes, apple green birefringence. So the answer to this question is it's an amyloid deposition, and it might be due to a multiple myeloma showing you mesangial deposition of AL amyloid. AL amyloid. A mesangial deposition of AL amyloid. Now my question comes here. Tell me, in AL amyloid, what is the most common type of deposition? Whether it is kappa or it is lambda. Let me see how many of you can answer it. Most common is kappa or lambda. You have to answer this on the live chat. Let me see how many of you can answer it. Kappa or lambda? Fatafat, taratari. The most common is, beta, it is most commonly, it is lambda light chain, not kappa. The most common is lambda light chain, is the most common light chain deposition in the AL amyloid. So lambda is more than the kappa light chain, not kappa, it is lambda. Okay. Chalo, next question. Chalo, tada, tatadi. What is your next interpretation? What do you see here? So what do you see here is a Winddrops tube. What you see here is a Winddrops tube. Okay. You see here is a Winddrops tube. Okay. Winddrops tube. Now I have a few questions to you. Winddrops tube and Westergren tube. Westergren tube. Winddrops and a Westergren tube. Okay. So my question is, which of them is closed, and what is the length, and what is the anticoagulant used here? Three questions might be asked from it. Let me see how many of you can answer it. Yes, it is used for ESR. That's very correct. Winddrop is closed. Length is 11 centimeter, that is 110 millimeter. And the anticoagulant is EDTA. Westergren is open at both the ends. Length is 30 centimeter, that is 300 millimeter. 300 millimeter, and it is sodium citrate. Sodium citrate is the anticoagulant used. Okay, anticoagulant used. Now in this image, if you look at this image, look, there is a, these are the settlement. RBC has settled down below. RBC has settled down below. Now you look at this 0 here, and settling to what level? This 20 written here, it might be 18 here. So you will say that the ESR here, the ESR measurement by Winddrops tube here is 18 millimeter. And suppose it has been read after 1 hour, I'll say 18 millimeter in 1 hour, not per hour. I'm very sorry for this mistake. It should be in 1 hour. 18 millimeter in 1 hour. Abhishek, Bahubali, not Bahubali. Yes, Bahubali. ESR is a bit raised here. I won't say exactly it is normal. It's a bit raised. Now comes a question to you all. Let me see how many can answer it. ESR is 0 in. ESR is 0 in. Bolo, answer, Dada. In which condition will you see the, in which condition will you see the ESR is 0? Let me see how many of you can answer this question. Yes, ESR is 0 in. The correct answer is A fibrinogenemia. Okay, in A fibrinogenemia, ESR is 0. This is a question that has been asked. One more answer of this can be A sickle cell anemia, okay, a sickle cell anemia will also have a 0 ESR. Sickle cell anemia will also have a 0 ESR. Okay, will have a 0 ESR. Fatafat. Identify the tube and their usage. So what I'll do is, let me just show you this tube one by one and let's mark it. What are the uses of the tube? Okay, what you should know in these tubes are, what is the anticoagulant and for what sample do we take here? Before we move here, let's first identify the anticoagulant here. See, in the black tube, you basically have what? A sodium citrate. Let me write it here. Okay. But purple color has dipotassium erythritate, and sample we use is for the complete blood count. Okay. In the black, what we have sodium citrate. Sodium citrate 3.8%, and we take the blood ratio as 1:4. The use is to measure ESR. Now, if I ask which tube, Westergren tube. However, for a ESR to be done by Winddrops, you need what? EDTA tube. Okay, EDTA tube. What else should you know? A light blue. Okay, a light blue. Light blue has again sodium citrate 3.8%, but here the ratio is 1:9. Ratio should be 1:9. 1:9. Okay, the light blue, it has coagulation step like PT or APTT testing. Okay, next one. What else should you know? Green. Yeah, green. It is heparin. Very good. Heparin used for ABG. And do not forget electrolytes like sodium and potassium. Sodium, potassium, lithium, they all should be sent in the green tube. And the gray tube, it has potassium oxalate and sodium fluoride. Potassium oxalate and sodium fluoride. It is used for glucose. Yes, green is heparin. Now, let me ask you a question. In COVID-19 infection, you are sending a sample for D-dimer. D-dimer. Heard about it? D-dimer. In which tube would you send a D-dimer investigation? In which tube would you see a D-dimer investigation? In which tube would you see a D-dimer investigation? The answer is light blue. Okay, light blue. Okay, I have a few questions. Sir, our biochemistry faculty told not to underfill a blue beta because you have to maintain the ratio, right? So if you are underfilling it, the ratio is not maintained. So the blue tube or any tube should at least maintain the ratio here. Unless the ratio is not maintained, your value will not come normal. And what is the ratio? 1:9 here and 1:4 here. For osmotic fragility, you send a sample in a green tube. Okay, green tube here. You also osmotic test, you send in a green tube. Not in plain tube. No, not in plain tube. We have to send in light blue tube. Not in green tube. We have to send in light blue tube. Light blue. Okay. Why? Coagulation है ना? D-dimer is a coagulation test. So you have to send this in a light blue tube. Next. So 8-year-old presenting to the AIMS OPD with transfusion dependent anemia. That means he might have a severe anemia and hemoglobin is 5 gram%. So there is hepatosplenomegaly and peripheral vein examination has been shown here. Look at this image. What is it showing you? These all cells are target cells. These all are the target cells. Okay, these are the target cells. Target cell is seen in any condition which has it's a target cell. Okay, next question. Yes, Codocides. One more name is Codocides. A 10-year-old male a 10-year-old male is presented to the medicine OPD with mild jaundice, okay, and pain abdomen, mild jaundice and pain abdomen. Her father gave a history of similar complaints along with recently opted for gall stones, recently operated for a gallstone. History giving you hepatosplenomegaly, hepatosplenomegaly. There is jaundice, there is pain abdomen, there is gallstone operation. What else do you need? These all are showing you what? Is showing you spherocyte. They're showing you spherocytes. The most common defect with spherocytic anemia is, yes, you all guessed it correctly, it is ankyrin. Okay, it is most commonly, it is ankyrin. Very, very good. Amit, Arunava, Rajat, very, very good. Maria, Vicky, Amit, Nidhi, Prashant, AK, Rajat, Avinash, Arunava, Maiti, Amit, Prashant, very, very good. Okay. What is in the red tube then, sir? Red tube, beta, red tube is for those sample being sent for the routine biochemistries, like for the hormones or for the, LFT, KFTs, lipid profile, they all are sent in the red tube or the yellow tube. Red tube or the yellow tube. Okay. 12th. Identify the marked question in the given figure. Okay, marked question in the given figure. Please share the video with most of your friends so that they can also join the discussion, and let's have some fun. Okay, there's no exam pressure. We are doing it for learning purpose. So share the video as much as possible so more and more of the students can join this. Okay. Well, this is an interesting question. How is Ashwini sir? Ashwini sir is very, very well. He's very good. Now he's very good. He's recovering from his infection. Yes, he didn't take the vaccination because he was a bit busy that time. Now he realizes that he should have taken it. But yeah, I think now you got the point. And for the cell that is marked here, so what is this cell? Well, this cell is, guys, what is this cell? These all are the helmet cell. Yes, helmet cell, also called as cystocyte, helmet cell or the cystocyte. Okay, it looks like this. That's it. Okay. Now, can any of you tell me what are these cells, guys? These cells or these dark looking cells? Can anyone tell me what are these cells? These dark looking cells? Well, these cells are polychromatophil. Polychromatophil. Also called as reticulocyte. These are called reticulocytes. Now, reticulocytes are stained on supravital stain. But when you stain them on Leishman or Giemsa, they appear as this dark blue. Look at this dark blue color, and hence the name they're called as polychromatophils. They're called as polychromatophils. Okay, they're called as polychromatophils. Okay. Next question. The given figure is showing you a special stain. The same polychromatophil, when it's stained by this supravital stain, they're called as reticulocyte. Now, reticulocytes, these are actually a type of stain by supravital stain. The stain by supravital stains. Now, what are the examples? New methylene blue. Okay, brilliant crescile blue. Okay, brilliant crescile blue and crystal violet. Okay, and crystal violet. So the answer is brilliant crescile blue. Pearl stain is same as Prussian blue stain, is used to stain what? The ferric stain. Okay, that is Fe, ferric. It's used to look for ferric. Romanowski stain is the Leishman and Giemsa. Okay, Leishman and Giemsa are the Romanowski stain. Okay, so Giemsa is what? Again, it's a type of Romanowski stain which stains for both a blue, that is nucleus, and pink, that is cytoplasm. Both of them can be stained here. Next question, guys. Fatafat. So, what is the disease this patient is suffering from? So, what is the disease? Can you look at this image and tell me? What is the image showing you? Well, these cells are, yeah, target cells. And these cells, the arrow marked cells, these are sickle cells. The sickle cells. Okay. So, what is it? It's a sickle cell anemia. The sickle cell anemia. Okay, sickle cell anemia. Now, what are pencil cells? Pencil cell are cell like this. Now, you might be saying, so they are looking the same like sickle cell. Sickle cell will look like this. They don't have a pallor. They don't have a central pallor. But pencil cell will have a central pallor. Cigar cell is same as a pencil cell. They also are the same as pencil cell. Cigar cell is same as pencil cell. Same name. Teardrop cell, they are seen in myelofibrosis. They are seen in myelofibrosis and sometimes also in megaloblastic anemia. They are also seen sometimes in hemolytic anemia. But if you have all the choices with you, the best answer is myelofibrosis. Yes, pencil cells. Very good, Rajat. Pencil cells are seen in iron deficiency anemia. Nasreen, Ashwarya, Avinash, Dr. A.B., Lekhya, Arnava. Very good. Maria, Amit. They're seen in all these three, 1, 2, 3. But if you have one answer, this is the best answer. Myelofibrosis. Okay, myelofibrosis is the best answer. Now, this question is again the same. So, what is this image showing you? It is showing you teardrop RBC. Teardrop RBCs. Okay, these are the teardrop RBC. Teardrop RBCs. And I told you the conditions in which they are seen in myelofibrosis, megaloblastic anemia, hemolytic anemia. All these conditions are where you can see the teardrop RBCs. Okay. What does this peripheral smear show? So what are you seeing here? These are showing you what? Look at this. These are ROULEX, Roulex formation. They are showing you Roulex formation. Okay, Roulex formation. Roulex formation is what? It is a condition in which the RBCs, they all make a chain like this. Now this condition is not specific for multiple myeloma, because apart from multiple myeloma, it is seen in any condition in which the protein is high, like for example hyper gamma globinemia, for example severe infections, tuberculosis, Kala-Azar will show you, and will also be seen in severe anemia. Okay, Roulex formation. Okay, the three conditions will show you Roulex formation. Okay. Now, can you tell me how will you differentiate between agglutination and Roulex formation? Can any of you tell me how to differentiate agglutination with Roulex formation? Let me see how many of you can tell this answer. How many of you can tell this answer? Let me see. How many of you can tell this answer? How to differentiate agglutination with Roulex formation? The correct answer is you mix the blood with normal saline and then again make a smear. Agglutination will disappear. Roulex formation will not disappear. This is how you differentiate them in a lab. Okay. No, by shaking you will not be able to remove the agglutination. It's not possible. By shaking is not possible. You have to mix them with normal saline and again make a smear, and then you have to see what disappears. What disappears is agglutination. What does not disappear is Roulex formation. Okay. Roulex in stacks always. What do you mean by this, Suraj? Coombs test. But a Coombs test was not the option. You have to see them only by this. But I can tell you, Coombs test may be positive agglutination, but Coombs test may also come negative agglutination. Okay. Okay. Because why I'm telling you this question, because if you look at this image here, this may look as agglutination. This clear-cut Roulex formation, but this here may look like agglutination. So this often is a confusing statement for a pathologist, and we have to differentiate in this manner. Okay. Now the next question. Identify the marked condition here. So what do you think is this? What are these? These are actually called as correct answer is Howell-Jolly bodies. Okay. Howell-Jolly bodies. Howell-Jolly bodies are what? They are nuclear remnants. Okay, the nuclear remnants. Sometimes what happens inside the RBC, you'll see a light pinkish circle like this. These would be called as a Cabot rings. Cabot rings are mitotic spindles. Okay, mitotic spindles. They are mitotic spindles. Now it might be asked, in which condition do you see Howell-Jolly bodies? So Howell-Jolly bodies and Cabot rings, they are seen in three conditions. They both are seen in the same condition, 1, 2, and 3. Number 1, it is megaloblastic anemia. Number 2, they are seen in hemolytic anemia. And number 3, they are seen in the after removal of spleen. So post splenectomy. The three conditions which you can see this: megaloblastic anemia, hemolytic anemia, and post splenectomy. Now you have to answer me this: where do you see Dole bodies? Yes, let me see how many answer this question. Swati, Dr. Amit, again Avinash, Piyush, Prashant, Suraj, Shari, Amit, Doctor. So, beta, answer. Dole bodies, where do you see this? They actually are seen in sepsis. What are these? These are endoplasmic reticulum. Yes, they are seen in sepsis or infection. They are endoplasmic reticulum. What are basophilic stippling? These are abnormal hemoglobin seen in thalassemia and seen in lead poisoning. Papillary body are iron deposits near the membrane. Iron deposits in membrane. So they're seen in iron overload. They're seen in iron overload conditions. Any condition there is iron overload like hemochromatosis or repeated blood transfusions, you can see the Pappenheimer bodies. Yes, very good, Amit. These are dilated endoplasmic reticulum. Very, very good. Piyush has joined. Very good. Mariama, yes. Lead poisoning. Arunava Maiti is lead poisoning. Very, very good. Very correct. Okay. Sideroblastic anemia. Yes, you can see that in sideroblastic anemia also. So any condition in which you can expect iron overload, you can also expect Pappenheimer body. Next question, guys. Okay. Which of the following is seen by a red arrow? The most easiest and the easiest question of all of what I will be showing you today. It is undoubtedly a hyper-segmented neutrophil. Hyper-segmented neutrophil is having more than equal to 6 nuclear lobes. 5-pyrimidine nucleotidase deficiency. Baba, Suraj, khub bhalo. Yes, that's also one, but it's very rare cause. Yes, okay. So hyper-segmented neutrophil is more than equal to 6 nuclear lobe. It is seen in, yes, megaloblastic anemia. Okay, megaloblastic anemia. Let's move forward. Identify the cell and the given condition. What is this given condition, guys? It is, yeah, hairy cell leukemia. So this is the cell, this is a nucleus. Okay, and these are the hairy projections. They're hairy projections. What do these hairy projections contain? What do they have? This is my question. Tell me, what do the hairy projections contain? What do the hairy projections contain? They contain, the correct answer is Golgi bodies. They have Golgi bodies, and they're best seen in the phase contrast microscopy. They're best seen in the phase contrast microscopy. They don't have ribosomal RNA. Ribosomal RNA are seen in reticulocytes. Okay, reticulocytes. They are Golgi bodies. They don't have RNA ribosomes. They have Golgi complexes. Okay. And where the marked cell here. So what is this marked cell, guys? These are binucleate apparence, owl eye apparence. The binucleate owl eye apparence. They're called as Reed-Sternberg cells. Suraj, the criteria for hypersegmentation is at least one neutrophil with 6 lobes or 5% neutrophils with more than 5 lobes. Okay, you're asking me this na, one neutrophil with more than 6 lobes or 5% with more than 5 nuclear lobes. This is the definition. Okay. Yes, they're mostly seen due to the CMV infection. It's Reed-Sternberg cells. Reed-Sternberg cell. Okay, seen in Hodgkin's lymphoma. Very true. It's Hodgkin lymphoma. Okay. Next question. Diagnosis. Straight diagnosis. No history given. No history given. What is it? No history given. What do you think it is? Come on, fast. These are myeloblasts with OR rods. But what is OR rod? OR rod are primary granules. Okay, OR rods are primary granules in the myeloblasts. Now, if you see a cluster of OR rods like this one, clusters, they are called as faggots. Cluster of OR rods are seen in faggots. They're most commonly seen in AML M3. They're seen most commonly in AML M3. Okay, AML M3. That is acute promyelocytic leukemia. Okay, identify the cells. So what cells are these? What are you seeing here? You basically are seeing a cell in which the nucleus has been pushed to the periphery here. Nucleus has been pushed to the periphery here. So the reason is because the cytoplasm has a very light faint bluish. Cytoplasm has a very light faint bluish color here like this. Okay. So why it is happening? Because this area, which is called as perinuclear Hoff, they actually have again Golgi bodies. They again have Golgi bodies here, and that is what pushes the nucleus to the periphery. Such cells which are eccentric nucleus are called as plasma cells. Very good. They're plasma cells. They're plasma cells. They're not lymphoblasts. Why are they not lymphoblasts? Because if you look at this image very clearly, these are cells, and nucleus is not in the center. It's not in the center. Okay, they're very clearly showing you it's in the periphery. Look at this cell, peripheral size nucleus. They're not lymphoblasts. These are eccentrically placed. Look at the eccentric on one side, eccentrically placed. Look at the eccentrically placed nucleus. These are what? These are plasma cells. These are plasma cells. They're plasma cells. Plasma cells. Okay. Cartwheel appearance can be seen. Yes. Mott cells. Yes, that can also be seen. Flame cell can be seen. Okay. What other diagnosis by looking at this image? What do you think are these cells? Well, these cells are actually seen in CLL, chronic lymphocytic leukemia. These are all the mature lymphocytes. These all are the mature lymphocytes. Okay, and look at these one. These are smudge cells. They're smudge cells. The smudge cells. Okay, now therefore it is a diagnosis of CLL. Okay, now if I ask you what is the most common mutation in CLL, answer is 13q deletion. Okay, the CD marker of CLL, it is CD19 positive, 20 positive, 21 positive, and along with this 23 positive, 5 positive. Now these are the very important to remember. CD5 positive and also CD23 positive. Okay, 5 positive and also 23 positive. Yes, some books call this parachute cell, some books call this broken cell, but the best answer is smudge cell. Okay, let's put there only. Okay, it is fragile due to Vimentin defect. Yes, it's believed to be so. Yes, it's believed to be so. Yes, it's called as convent girl appearance. Very good. It's called as convent Convent girl appearance is the other name for this. Convent girl appearance. Convent girl appearance. Okay. Now, what is your interpretation by looking at this image? There is definitely a translocation shown here. Along with that, there is a peripheral smear here. Peripheral smear here. So, what do you think is this? What do you think is this? The correct answer is, let's identify this. Now, the correct answer is, if you look at this one, it's a blast. Okay, it's a blast. Now, these all cells, this one, this one, this one, these are actually the band forms. Okay, it's a band form. This also is a band form. Now, okay, this is a band form. These are what? They are myelocytes. They're myelocytes with the granules. They're myelocytes here. This is a eosinophil. Eosinophil. So because of plenty of cells being seen here, it's a garden party appearance. Okay, it's a garden party appearance. And look at this one. There's a BCR avial translocation, which signifies it's a PH chromosome. It's a 12 chromosome. So it is a chronic myeloid leukemia, and therefore it is what? It's a chronic myeloid leukemia. Okay, why CML? Because of the presence of BCR avial translocation, and therefore they should respond to the BCR avial translocation inhibitor, that is the tyrosine kinase receptor inhibitor, which is imatinib. Okay, let's now move to a few questions. I have around 30 questions, so 5 are remaining. Identify the casts here, A, B, and C and D. If you look at them, look at this cast here. A, it is very lightly stained cast. It is what? It's hyaline casts. Okay. Look at this B. These are granules type, and hence it is B, granular casts. Okay. Look at this C. These are cells here. These are all cells in this cast. These are WBC casts. Okay. These are WBC casts. Okay. And look at the D. Look at this one. The broken here. These are D. These are what? Yeah, these are broadcasts. Okay, they're seen in broadcasts. Okay, they're seen as a broadcasts. Okay, they're seen as broadcast. Remember this. Now, a question can be, which of them can be seen normally? The answer would be hyaline cast can be seen normally. A question can be, which of them is seen in chronic renal failure? Broadcast is seen in chronic renal failure. Which of them can be seen in acute pyelonephritis? Answer is WBC cast. Is seen in acute pyelonephritis. And granular cast, they have granules, and the granules are seen in, yeah, they're seen in mostly ATN, acute tubular necrosis. Okay, acute tubular necrosis. And hyaline cast can be seen in any cause of proteinuria. Okay. Kidney biopsy finding and ophthalmoscopy finding from a patient of type 2 diabetes has been shown here. Now, I hope you remember the previous image I have showed you of AL amyloid. This image is also looking more or less same. This pinkish color here. But the difference is, this image is showing you with a history of ophthalmoscopy finding, and the patient has a history of type 2 diabetes. So this usually it can't be AL amyloid, especially there is no such polarized microscopy finding. And this is basically what? It's a Kimmel-Steele Wilson nodule, also called as nodular glomerulosclerosis. Nodular glomerulosclerosis, like this here. Okay. Now these are what? This area here. You look at this area, this one. This is what it is. What is it? This is a capsule. Which capsule? Bowman's capsule. And like a drop is falling from the capsule. The drop is falling from the capsule. This capsule is called as capsular drops. It's called as capsular drops. They both are seen in diabetes mellitus. They both are seen in diabetes mellitus. Okay, they both are seen in diabetes mellitus. Again, a very, very important information that you should all know about. Okay, they are seen actually is diabetes mellitus. Now, my question can be the most common lesion in diabetes. My question is most common lesion in diabetes. The correct answer is not nodular but diffuse glomerulonephropathy. Second question, how will you stain a Kimmel-Still-Wilson nodule? How will you stain a Kimmel-Still-Wilson nodule? Correct answer is you can stain them with PAS. They're PAS positive. They're PAS positive. Kimmel-Still-Wilson lesion are more common in type 1 or type 2. It's mostly seen in type 2. Okay, it's mostly seen in type 2 diabetes mellitus. Now, a 35-year-old male patient has paleness hematuria. Okay, they have paleness hematuria. Okay, now CT scan shows a mass in the upper pole of right kidney. Partial nephrectomy was done, and histopath of result specimen has been shown here. Look at the histopath here. So, what are our guesses? First of all, look, this is a big mass in the kidney. So, a big mass in the kidney, it can be a tumor, right? Now, in a kidney, what tumor do you expect? The kidney tumor that you might expect is what? A clear cell carcinoma, a papillary cell carcinoma, chromophobic carcinoma, and brain duct carcinoma. But if you look at this image will show you a very clear-cut finding, and that is, look at this carefully. These are cells and the nucleus being pushed to the periphery with a whitish clear vacuole. Look at this cell, round cell, nucleus here, and look at the white vacuole here. Look at the very clear-looking white vacuoles here. So beautiful looking, clear white vacuoles. The clear white vacuoles here. They're clear white vacuoles here. Okay, the clear white vacuoles. So clear white vacuoles are seen in which carcinoma? Very, very good. Very, very good. It is seen in clear cell carcinoma. Clear cell carcinoma. But now you should understand which one shows what type of mutation. Now see, a clear cell carcinoma, it is having a VHL gene mutation. They are unifocal lesions. They come from proximal tubules, and MET gene is not involved because MET is involved in papillary cell carcinoma. MET is involved in papillary cell carcinoma. Okay, MET is involved in the papillary cell carcinoma. Okay, a 50-year-old male was admitted to the hospital due to a road traffic accident, and he was put on mechanical ventilator. Okay, now 10 hours after admission, he has a sudden dip in oxygen saturation being measured a lot nowadays, and you all know about it. Chest X-ray was done with no significant abnormality. Chest X-ray was normal. See, if a patient would have been, in that case the answer would have been ARDS. But in this history, it is what? It is saddle-shaped pulmonary embolism. Yes, it is saddle-shaped pulmonary embolism. It's saddle-shaped pulmonary embolism. The most common site of this is at the bifurcation of pulmonary artery. The most common origin is deep vein thrombus in the legs. That is called as phlebothrombus. Deep vein thrombus in the legs is the most common area from which they actually arise from. The most common area from which they actually arise from. Okay. Okay. So a second last question. A 60-year-old male, a chronic smoker, presents with casualty, with shortness of breath, fatigue. The CT scan shows a higher left lung lesions, and the biopsy was done, which shows the image as shown here. What do you see? You see this lung, and you see a big mass in the lung. There's a big mass in the lung, right? There's a big mass in the lung. Okay. Now look at these. Guys, what are these? Any guesses? What are these? What are these cells? What are these? What are these? This should be an image you should identify. At least you should identify here. What are these? These actually are what? What are these? Batao. Yes, they are keratin pearls. Very, very good. These are keratin pearls. Very good. These all are keratin pearls. These all are keratin pearls. And what you see here, these all are malignant looking squamous cells. These are mitotic figures. They're mitotic figures, and these all are malignant looking squamous cells. Malignant squamous cells. And hence it is actually squamous cell carcinoma. Okay, the keratin pearls here, these all are malignant squamous cells here also and here also. But for you, the image that you would be given is definitely this one. Why? It is showing you very clearly looking a malignant squamous cells. Malignant squamous cell is very clearly looking being seen in this image. Okay, in this image. Okay, the last question, guys. The last question. This is the question. So, a 24-year-old male had a swelling in the anterior aspect of the neck. On examination, the swelling was firm, moved with deglutination, and biopsy from the lesion has been shown here. Biopsy of the lesion has been shown here. What do you think it is? What do you think? This is the last question. So every one of you should answer. Any person who has not answered till now, I want you all to answer. Don't request you. I want you all to answer in the group. What is it? It is a thyroid swelling, right? It's a thyroid swelling. Why? It is moving deglutination. And now look at these. Take 1 and 2. These are what? They are finger-like projection. These are papillary projections. They're papillary projections. They're papillary projections. Okay. Now, if you look at the cells inside it, look at these cells. Look at these cells. What is interesting note here is, if this is a papilla, the cells are here, and usually the malignant cells are very, very dark. Usually the malignant cells you expect and you draw always is very dark like this. Usually like you draw a malignant cells like this. But what you see in this case is definitely you don't see such findings here. You don't see this finding here. But what you are able to see is the malignant cell is showing you, see here, clear looking a dark area, but a clear looking white area inside it. Dekho, yahan par beech mein, this one. Look at this one. This is called as pseudo inclusion. This is called as a pseudo inclusion. They are called as pseudo inclusions. The pseudo inclusions will remind you of someone. And who is that someone? Let me show you. Who is that someone? Let me show you. So who is that someone? Right. Sorry. I was searching something wrong, right? So if you look at that tumor, this is a tumor you will be actually looking at. Look at this beautiful looking papilla. Okay, look at this beautiful looking papilla. This papilla are here like 1, 2, 3, 4. These all are the finger-like papillas. Now what you see here are this a girl. In this girl eyes, look at this girl eyes. The girl eyes don't have this eyeballs like this. The girl's eye don't have the eyeballs. Look at the girl's eye. The girl's eye are completely white and empty. Her name, this girl's name is Little Orphan Annie. And the image will remind you of this girl. The girl's name is Orphan Annie. And therefore it is called as Orphan Annie eye nuclei. It is called as Orphan Annie eye nuclei. Now let's see this Orphan Annie eye nuclei. Look at her. Look at this cell. Now what you're seeing is, look at this white area of the cells here. Look at this white area cells. Look at this one. These all are the white cells you see here. And hence this is being called as Orphan Annie eye nuclei. Now any idea what are these? These are very well said by Sabyasachi. It is cytoplasmic invaginations. the cytoplasmic invagination in the nucleus. Cytoplasm is white in color. So what happens sometimes is cytoplasm is actually in going inside the nucleus, and therefore while staining you look at these white areas because they look like the eyes of that girl, and hence the name is orphan Annie eye nuclei. They're called as orphan Annie eye nuclei. They're called as orphan Annie eye nuclei. Okay, so this is where I end my today's lecture. I hope you liked it. It was short, but I think we learned a lot of things. I am very sure that if you want, we will come up with various other ways of teaching you. By that time, join my Telegram group, join my YouTube channel, and definitely keep on asking us a lot of doubts that you have so that we can answer this in the best possible way. Well, if you want this PDF, will also be available in that Telegram group along with some other images which I did not discuss with you, but I am very sure that you would be able to solve them. Okay, so thank you guys. I'll be sharing this PDF in my Telegram group. My Telegram group, I'm just posting my Telegram group in the chat here. So if any of you have it, you can also share it here. Else, I'll just share that. I'm just sharing the Telegram, my Telegram, own Telegram group link. You can all join from here. But anyhow, if you have any doubt, please do ask me there, and make sure the learning should never ever stop. You should keep on learning. You should keep on learning, and you should keep on enjoying the things. And if any doubt, please do let me know. Maybe I can help you to understand the things in a better conceptual way. Okay, in a better conceptual way. Okay. Yes, Piyush, I too am a big fan of you and entire GMC Bhopal. So take care. Goodbye. God bless you all. And do share the video. We can also help others to learn from it. And always remain happy. No, any doubts that you have, you may just please ask us. We may also be able to bring you some clinical lectures, some clinical discussions, or interpretation of ABG, interpretation of diagnosis in COVID. We can ask you, or we can present, or we can discuss some of the important thyroid function tests, lipid profile tests, kidney function tests, liver function tests, hemat function tests, and what not. Everything is pathology, right? So whatever you want us to bring a lecture on, let us know. We may be able to help you in that way. We can discuss it ourselves. We can have a fruitful discussion in ourselves so that we can learn in the best possible way, even though we are sitting in our homes quite safely, and we can learn a lot of things even from the comfort of your home, but being most importantly safe as you must be. Okay, so thank you guys. Take care. God bless you all. Stay happy and keep smiling. Bye bye.